Hello, everyone. This is Matt Schaefer. Thanks for joining us for the next episode of Wright State University's General Surgery Didactics. Today, we're going to be talking about abdominal trauma, part 3, solid organ injuries. We'll be discussing focused assessment with sonography for trauma or the FAST exam, as well as hepatic injury, how to manage it, and splenic injury and how to manage it. Starting off with the FAST exam, those of us who've spent enough time with Dr. Miner know that it has been specifically studied for blunt trauma patients who are hemodynamically unstable. It takes about 150 to 200 milliliters of blood in the belly before it'll be positive on a FAST exam. And it's not necessarily validated in patients with penetrating injuries. That said, there are no absolute contraindications to a FAST exam, and patients should be examined regularly, and any change in vital signs or exam findings can be an indication to repeat a FAST exam. So it's important to keep in mind that you want to make sure you're getting your pericardial window in the subxiphoid region, your right upper quadrant Morrison pouch, left upper quadrant splenorenal space, and the suprapubic space. We'll also talk about the EFAST, which is including bilateral lung windows to look for any pneumothorax. Some things to keep in mind is that blood is going to be hypoechoic or anechoic or dark on your ultrasound when you're performing it, and air is also going to be anechoic or completely black. For your pericardial view, you want to make sure you're putting the transducer in the subxiphoid region directed toward the left shoulder underneath the xiphoid process, and you need to be able to see both the anterior and posterior pericardium. And again, Dr. Miner will tell you that know that you have a true image to rule out any pericardial effusion. You do have to be able to visualize the aorta deep on your exam. Next, you have the right upper quadrant view. You want to be in the right mid-axillary line at the level of ribs 9 to 12, a little bit different based on age and lung volume. And this will show you the diaphragm-liver interface as well as Morrison pouch. Next, you'll have the left upper quadrant view, which is a little bit more superior and posterior than the right upper quadrant. Typically, when you're doing it, you want your hand all the way down on the table as you're looking into the left upper quadrant, and you should be able to see the diaphragm and spleen interface as well as the splenorenal interface. Next and last in the traditional FAST exam, you have the suprapubic view. You can place the transducer just above the pubic symphysis. I like to fan both inferiorly, superiorly, as well as transversely to make sure you're getting complete visualization of the bladder and looking for any free rupture. Now, say you have a blunt polytrauma patient with a seatbelt sign across the chest, and you're not sure, there might be some diminished lung sounds on one side. You can extend that FAST exam, perform an EFAST, and place an anterior view of the bilateral hemithoraces. In this case, you're looking for pneumothorax, you're really looking for lung sliding, and we'll talk about the findings for that. Here we see the 4 traditional windows of the traditional FAST exam. And here we have that pericardial window, and you see the 4-chamber view of the heart. Not super easy to visualize the aorta in this one, but something to keep in mind when you're actually performing a FAST exam. Next, we have the right upper quadrant. We can see Morrison's pouch here, fluid accumulating right in Morrison's pouch. Next, we have the left upper quadrant, and here we see a little bit of fluid accumulation in our splenorenal space. Then we have the suprapubic window, bladder window. Here we can see some rupture of the bladder. And then finally, we have our bilateral hemithorax window for the EFAST. And what you're really looking for here is the ants on a log appearance, or the crawling of the pleural lining. If you don't see that crawling sign, then that is indication of pneumothorax. Some additional considerations for the FAST exam is to make sure you have the correct transducer selected. So you can use the curvilinear transducer for all of the abdominal windows on the FAST exam. However, you might get a slightly better view if you use the phased array or cardiac probe for the pericardial window, and a better view with the linear probe looking for lung sliding. Then make sure you have enough gel and you adjust the gain and the depth appropriately so you get your correct windows. And you want to keep in mind that this exam really should be performed in 5 minutes or less. So if you're not super experienced with it, if you have a stable trauma patient, that might be someone that you want to try practicing on or using it in the cadaver lab to increase your proficiency. And while you're performing the fast, you should really be considering whether the patient is hemodynamically stable versus unstable, and whether your fast is positive versus negative to help you with deciding when you're going to go to the operating room, or if this patient is stable for further imaging in the CT scanner. Some limitations that we already discussed is that the FAST exam does require 150 to 200 milliliters of intraperitoneal fluid in order to register as positive. As with anything with the ultrasound, it is going to be user dependent, so practice is important. There is a lot of false positives and false negatives because of that. And here we just have some examples of a positive finding on the FAST exam that in a hemodynamically unstable patient would be indication to proceed to the OR. Now moving on to solid organ injury, we're going to talk about the liver first. In hepatic injury, it is important to identify where the liver is injured and whether the patient is hemodynamically stable or unstable to determine whether you're going to treat it operatively or non-operatively. Important to keep in mind, the liver is the most common intra-abdominal organ injured in blunt trauma. It's also mostly contained sort of within the rib cage, so you do have to consider liver injury to patients with blunt or penetrating chest trauma as well. And going back to blunt injury, the most common area of injury is the posterior portion of the right lobe of the liver. Now, obviously, the liver is a very well vascularized organ, as we can see in the photo to the right, and extreme blood loss can lead to acidosis, hypothermia, and coagulopathy. We are familiar with this as the lethal triad in trauma, so it is very important to get control of bleeding as soon as you recognize injury. When a patient presents into your trauma bay, they may have chest wall injury, right flank bruising, right-sided abdominal pain, or they might not have any signs or symptoms at all, but that doesn't necessarily rule out hepatic injury. It's always important to keep in mind that a trauma patient is bleeding until proven otherwise, so keep a high index of suspicion that your patient is hemorrhaging. Another thing you'll have to consider in trauma surgery is that you'll have to mobilize the entire liver to control hemorrhage and correctly pack it. So you'll have to take down falciform ligament on your way into the abdomen, and then you'll also have to mobilize the liver by taking down the right triangular ligament, left triangular ligament posteriorly. Again, FAST is a useful tool for identifying hepatic injury or hemorrhage. Unfortunately, it does have the high negative rates as we discussed earlier. CT scan is another useful imaging technique for diagnosing and classifying the severity of hepatic injury. So talking about grading and severity, we have the AAST liver injury grading scale over here to the right, which you can read and appreciate on your own. But for those of us who understand this better by seeing, we'll take another look at some other ways of visualizing this. Here's some example images of what each of the grading severities looks like grossly. And then here we have some examples of what we see radiographically. You see with grade 1 you have this small subcapsular hematoma, grade 2 a little bit bigger hematoma, or kind of a stellate laceration here. Grade 3, obviously pretty significant involvement of the right hepatic lobe, and then pretty deep lacerations. Down here, grade 4, pretty significant involvement again, now extending kind of beyond just the one lobe. And grade 5, we have pretty much through and through injury here through the liver. Okay, so what do you do about hepatic injury? We'll discuss operative management pretty shortly, but in some cases you can consider non-operative management. Typically you do this in a hemodynamically stable patient, and the most common adjunct would be arterial angiography for embolization of some of the vasculature to the liver. Liver is a highly vascular organ, as you can see over here at the right. In fact, up to 85% of patients with blunt hepatic injury can be managed non-operatively, as long as they're hemodynamically stable and don't have active extravasation on CT scan. These are good indications that you can monitor them. Some risk factors for failure of non-operative management include advanced age, high-grade injury, large hemoperitoneum, pseudoaneurysm, or contrast extrav on CT. And then patients who have penetrating injury are obviously going to be managed operatively. So we talked about the operative anatomy already a little bit, but say you have a patient who's hemodynamically unstable or they have a penetrating injury, you're going to go to the OR. How are you going to take care of them? Well, you're going to get them up and prep them in the usual trauma sterile fashion, chin to knees, anteriorly all the way down to the bed. Your patient's prepped and draped. Now it's time to get in. You make your midline laparotomy. First thing you'll encounter is usually pretty significant hemoperitoneum. So you'll evacuate that. You'll put directed packing in. Depending on the type of injury, you may pack all 4 quadrants and give it a moment to achieve some hemostasis. Or if it's a penetrating injury directly to the liver, you might have directed packing just to the right upper quadrant. You'll mobilize the liver, as we discussed earlier, by taking down falciform and the triangular ligaments and coronary ligament. And then again, you can use direct compression. Typically you'll use the sandwich technique or packing with the sandwich technique, or you can even attempt suture repair. This is going to be achieved with a absorbable suture on a blunt needle so that you don't cause even more traumatic parenchymal trauma. And say you have attempted all of these, haven't achieved adequate hemostasis, the next thing you can do is try mobilizing the hepatoduodenal ligament, encircle it and clamp it. This is your Pringle maneuver. And our SCORE curriculum did indicate that this can be done for up to an hour, but in practice and other sources I've seen have said you don't want to do this for more than 20 minutes at a time. So what you can do is apply your clamp, make sure you record what time you put the clamp on, work on achieving hemostasis for about 15 minutes, and then you might want to release the clamp, give the patient a few minutes to kind of revascularize the liver. Yes, you will lose some blood during this portion, but it also help you save the liver potentially, and then you can reapply that clamp for another 15 to 20 minutes. Unfortunately, this also might not solve the problem. So the next thing you can do is try a hepatic resection. Typically, you're going to do a stapled resection of the liver. You might want to use argon beam coagulation for the parenchymal edges to help with hemostasis. And in the unfortunate scenario that none of these work, you're probably dealing with a retrohepatic caval or a venous injury, in which case it's good that you have mobilized the liver. You need to try to medialize it or bring it forward as best as possible. Try not to avulse any of those retrohepatic veins, and try to perform a direct repair or potentially even just packing to those retrohepatic structures. So here we see kind of the sandwich technique for properly packing a liver. Depending on the orientation of the laceration, you want to make sure that you're putting compression, to push those parenchymal edges together, and leaving it in such a way that you're helping to create tamponade. What you don't want to do is to pack within the laceration, because this actually helps separate the parenchymal edges and can prevent you from obtaining hemostasis. And then here we see a very clean and atypical illustration of what mobilization of the hepatoduodenal ligament and cross-clamping or the Pringle maneuver would look like. In the real scenario, this is going to be a bloody mess, and a lot of it is going to be done by just manual evaluation. As we discussed previously, the liver is extremely well vascularized. In severe injuries, you're going to lose a lot of blood. And we talked earlier about the lethal triad of coagulopathy, hypothermia, and acidosis. And liver bleeding can lead to this lethal triad pretty quickly. So you really have to keep in mind your damage control option, that don't let great or perfect be the enemy of good enough. If you have good enough hemostasis and your patient is coagulopathic, you're never going to get it completely controlled, and that would be an indication to pack it as best you can and get out and get them to the ICU for resuscitation, with the plan to take them back in 24 to 48 hours. Some complications of liver injury include bile leak. Depending on whether a biloma is formed, you can consider IR-guided or CT-guided percutaneous drainage. If you're concerned about a biliary fistula, you can consider a GI consultation for ERCP. Patients may also develop hemophilia. This is typically on the order of days to weeks after operation, and is the result of hepatic arterial to biliary fistula. Typically, this is treated with hepatic artery embolization. And then some patients may develop hepatic necrosis. This is typically seen in patients who required operative management and required packing and arterial embolization for management of hemorrhage. And when this is seen, typically the treatment is CT-guided drainage by IR. And moving on to another solid organ, well-vascularized organ, we can discuss the spleen. Much like the liver, it has many ligamentous attachments. These are the splenophrenic ligament, which is avascular, and the splenorenal ligament, which is avascular when there's no portal hypertension. The gastrosplenic ligament, which is where our short gastric arteries live, and then the splenocolic ligament, which typically is avascular as well. The spleen itself lives in the left upper quadrant. Superiorly, it's attached to the diaphragm via that splenophrenic ligament. Posteriorly, it's associated with the left adrenal gland and left kidney. Medially, it is very closely associated with the tail of the pancreas, and that is where our hilar vessels exist. And then inferiorly, it's pretty closely associated with our splenic flexure of the colon. If you're pursuing operative management of a splenic injury, you should consider evaluating all of these organs for damage as well. Patients with splenic injury commonly are those with penetrating injury to the left upper quadrant or thoracoabdominal trauma, and blunt trauma patients typically will have injury to the left ribs or to the left flank. Again, in a patient who is hemodynamically stable or is a responder to fluids or blood products, you can first evaluate the blunt trauma patient with a FAST exam, or if that is equivocal, or even if it's positive but they're stable, you can proceed with a CT scan to evaluate for other injuries. Just as the liver has an injury severity scale, the spleen also has an AAST injury severity scale. The severity grading is here. Do take a moment to pause the video and review it, because these are test questions. But again, I find that pictures are pretty helpful, so we will look at those. And thankfully, the splenic injury scale or grading is pretty similar to liver. Again, you have a laceration less than 1 centimeter or subcapsular hematoma less than 10% for grade 1. Grade 2, I think of as laceration of 2 centimeters. It's really 1 to 3. 2 is right in the middle, and it's grade 2. And then you have subcapsular hematoma of, again, in my head, 20% for grade 2, but it's really 10 to 50% for your hematoma. For grade 3, the laceration is greater than 3 centimeters, and then subcapsular hematoma greater than 50%, just because it's more than grade 2. And then you also can have, in grade 3, a ruptured subcapsular or parenchymal hematoma. Grade 4 is typically where you get segmental hilar injury or devascularization of more than 25% of the spleen. And then grade 5 is your shattered spleen. And here's what those injury grades look like radiographically. Take a moment to pause the video and review them so that you're prepared to see them when you're looking at your own CT images. For management of splenic injury, we'll discuss operative management pretty shortly, but a lot of patients can be considered for non-operative management. Hemodynamically stable patients with blunt traumatic injury are usually good candidates for it, as long as they don't have a grade 4 or grade 5 injury. Patients with a pseudoaneurysm or just a specific vascular injury to the spleen and not so much the parenchyma are good candidates for angioembolization. Just keep in mind that patients with a grade 4 splenic injury have a failure of non-operative management of up to 33%, and patients with a grade 5 injury have a 75% risk for failure. So these, I would argue, should be managed operatively. And here we can see that after angioembolization, our active extravasation of our splenic injury is significantly improved. Okay, so say you have a hemodynamically unstable trauma patient, or you have one of those grade 4 or grade 5 injuries as seen on CT scan, you're going to want to proceed with operative management. We discussed the anatomy earlier. Just keep in mind how well vascularized the spleen is. And for preoperative preparation, you're going to prep them the same way you would any trauma patient, chin to knees of the entire torso, anteriorly down to the bed. You're going to go ahead and make your midline laparotomy. First thing you'll encounter is a lot of blood, so you want to section that out. And then you'll want to pack in all 4 quadrants, or for a penetrating injury to the left upper quadrant, you might do directed packing. You'll want to mobilize the spleen medially. A lot of times bleeding in the retroperitoneum is actually going to help you with your dissection. So you'll want to mobilize the left colon via the white line of Tolt, and a lot of times you can actually just get your hand in there along the abdominal sidewall and bluntly dissect out that plane that the bleeding is already kind of separating for you, in order to get up and around the spleen, taking down those 4 ligaments that we talked about previously, and then using your hand to rotate it medially and bring that spleen medially. In addition to the 4 ligamentous attachments to the spleen, you also typically want to mobilize transect the gastrocolic ligament to get into the lesser sac, so you can visualize the body and tail of the pancreas and make sure you don't have any pancreatic injuries. And once you've done this, if you have injuries isolated to the spleen, or if the spleen is your biggest source of hemorrhage, at this point you should be able to clamp across the hilar vessels and take the spleen out via resection, get the spleen in the bucket, and get out of there. Now, academic texts will frequently discuss splenography or partial splenectomy. In practice, these are rarely performed and really are more just academic discussion. Just like with liver trauma, you do have to consider massive hemorrhage leading to the lethal triad, so you'll have to consider when you need to pursue a damage control operation. And then splenectomies do also come with their sets of complications. These typically can be broken down into early complications and late complications. Even with non-operative management, the data suggests that splenic function is pretty well preserved after either proximal or distal angioembolization. And then another thing to keep in mind with your early complications is your platelet to white blood cell count ratio. Now, post-op day 5, well, you're going to see a leukocytosis and a thrombocytosis in all post-splenectomy patients, but if at post-op day 5 your platelet count to white blood cell count ratio is less than 20, that's a pretty significant indicator that the patient may have sepsis and needs some more aggressive management of bacteremia. Now, the most feared complication from splenectomy is a late complication. It's overwhelming post-splenectomy infection. Strep pneumonia is the most common organism. This is isolated in 50 to 90% of patients with OPSI. Again, this typically presents years after a splenectomy, but it does have very high mortality. So it's something that always has to be on your differential in a post-splenectomy patient. To try to minimize the risk for OPSI, we always talk about our splenectomy patients needing vaccines. Now, for a planned splenectomy, not your trauma scenario, typically you'll want these vaccines given at least 2 weeks preoperatively. In a trauma scenario or an unplanned splenectomy, you'll want to give these vaccines typically 2 weeks post-operatively. Unfortunately, we know that trauma patients often have a lot of other things going on in their lives. They have a lot of minding their own business to do. So a lot of times they won't show up for a post-operative appointment. So it is important to give them their vaccines during the same hospital admission to make sure that they get them. Getting the vaccines at a suboptimal timing is much better than not getting them at all. And another test question is that we're vaccinating against encapsulated organisms. Those are our strep pneumo, H. flu, and Neisseria meningitidis. And that wraps up our discussion about focus assessment with sonography for trauma, hepatic injury, and splenic injury. Thank you for your time.